Okay. We're going to move to the last presentation from Dr. Feldman, post-procedural anticoagulation management after LAA exclusion.
I think I'll have just a little bit of a different perspective than the last talk, so complementary, but I think the issues are the same. And I'm going to focus a little more on decision-making in the early post-procedure period. It is really remarkable when you go back and look at where all this started. And I got a couple of references here for the beginning on some of the earliest efforts at surgical excision of the left atrial appendage. And this was, of course, in the era where rheumatic valvular disease was the overwhelming substrate for atrial fib and the surgery that led to left atrial excision. But here's a series of a couple, and doesn't take a statistician to figure out that this is not a perfect therapy with 1-in-1 for survival. And a year later, a 6-patient series, a clinical observation that patients who had had multiple thromboembolic events after atrial appendage excision would generally do a whole lot better. But again, if you dig through this paper, obviously this was a different era. There were a lot of complications. Now, you've seen snippets of the surgical literature presented in several talks. One of my colleagues in our surgery group reviewed really the whole literature on modern techniques. We put together this beautiful drawing on the various approaches, and you see excision, truly removing the appendage and over-sewing it, is the only surgical technique that results in complete occlusion of the appendage, because if the surgeon doesn't succeed, it's just an intolerable bloody mess, so that they're forced to excise the appendage. But even with excision, these things can recanalize, and more importantly, when you go through all these reports, and you've heard these all critiqued at one time or another through the course here, you have to be highly cognizant of the definition of successful excision. And in the surgical literature, it is a residual pouch less than 2 centimeters, so that the nidus for thrombus is still there. And that's reflected in some literature that has looked at the outcomes of excision in surgical patients. This is probably one of the more recent. This is from Cleveland Clinic. It was presented as an abstract in 2002, and for some reason never made it into print in a full publication. And it found that in appendage excision associated with valve surgeries at the clinic, that the thromboembolic rate was higher in the LA ligation patients. And this reflects this incomplete excision as a risk factor for one, possibly the belief that stopping anticoagulation is made possible by left atrial appendage excision or occlusion. Here's an example from our own practice of a post-op left atrial thrombus. One view with the red arrow looks like a really gorgeous excision, and this was excision, removal of the appendage, and a double row oversew. But the red circle shows you in another view both the residual pouch and a nice little thrombus sitting there with a low echo density reflective of a fresh thrombus. And this is the typical post-op patient who's being, after a valve operation, being loaded up on warfarin. So this really captures the problem. Now, I think that most of us believe that therapy with devices has the potential to be better, and that's based on our understanding of pictures like this. And I think probably a third of all the speakers at this meeting have shown this one very well-known picture. The poor guy died from a AAA rupture 9 months post-Watchman, but look how beautifully that's healed. And you see this endothelial covering the screw end of the device has a glistening layer of endothelium, and this ought to be the magic bullet that gets us off of warfarin. So our best understanding of this population and how to manage anticoagulation is based on the Watchman protocol. And in this protocol, the patient takes warfarin for the first 6 weeks after device implantation, and then a TEE is performed. And I think the last talk was great in terms of emphasizing the need to look at every patient before you make a decision about stopping anticoagulation, because that was the paradigm in the Watchman trial. It wasn't just 6 weeks of Coumadin and stop the therapy. Now, why is it that we have to look? Here's the prototypic beautiful picture of a perfectly implanted Watchman with just a little bit of device shoulder sticking up over one edge of the appendage and a flush appearance on the right. But we don't always get it so nicely. And in fact, I think in real practice, most of the devices are tilted a little bit. There's a little extra sticking out, or there's a little bit of a rim of residual pocket of or mouth of the appendage. And clearly, with the variability of the pectinate muscles and these ridges that you find around the entry to the appendage, a nidus for thrombus. You just saw a detailed review of this paper out of the Protect AF trial looking at the impact of residual leaks. You see a nice picture of a residual leak there. The conclusion here was that peri-device flow is seen in a third of patients, not associated with an increased risk of thromboembolism. But when you start splitting people up into leaks of varying magnitudes, the numbers are way too small to safely make this conclusion. And you have to believe that if you looked at a big enough series of leaks, that you would see that they're not a great thing to have. Now, the only other data we have for guidance regarding the management of anticoagulation after device therapy with a Watchman is from the ASAP trial, and this is 150 patients in a registry, and you see the post-procedure regime, rather than Coumadin for 6 weeks, was clopidogrel for 6 months and aspirin indefinitely, with serial echo and TEE exams at 3 and 12 months. And we have the real data point here is the 1.7%. That was the observed rate of ischemic stroke in the follow-up period for this group of patients compared to the expected rate based on the CHADS-2 score of 7.3%. And what's fair to say here is that irrespective of the uncertainty of the comparator group, 1.7% is a really low stroke rate over a period of several hundred patient years in a population of patients like this. So that we have an idea that aspirin clopidogrel is probably reasonable after Watchman therapy. And I think, being optimistic and just assuming that after the PREVAIL data are presented at ACC by Dr. Holmes, that FDA will, within a matter of hours, send up a flare and approve the therapy, that aspirin clopidogrel may be utilized in practice a lot. Now that said, here's a picture of a Watchman device with a little clot hanging off the end of the screw thread, so that even with our best therapy, you can see this. And here's the thrombus on CT, negative image in the blood pool. So there are improvements coming, one of them mechanical improvements that should have an impact on this problem of device thrombus. The screw cap is going to have a lower profile in the Gen 4 device, and the Gen 5, if I can get to it, looks even more sleek with just a nicer profile. So hopefully the mechanical improvements in the devices will have an impact. The same thing exists with the Amplatzer cardiac plug. There are very, very much fewer data, so this is now all anecdotal, but you see here a thrombus on the screw thread of an ACP, and that's going to be addressed as these devices are made more sophisticated with a screw thread that's recessed instead of protruding. So there are some very simple things that should make a difference. I think I personally had the idea that the lariat procedure might completely mitigate the need for anticoagulant therapy because there's nothing left inside of the heart. And we have all seen really wonderful pictures of the fibrosis acutely and then the late fibrosis of the appendage with this device. And on 3D, the same thing. Here's a case from our own experience in a guy who had had repeated bleeding episodes, including 2 intracranial hemorrhages on aspirin alone and multiple strokes when he was off of all anticoagulant and antiplatelet therapy. So we ligated his appendage with Watchman. We did a 30-day follow-up TEE, and on absolutely no antiplatelet or antithrombotic therapy, he had this pretty large thrombus, and that led us to keep him on antithrombotic therapy for several weeks, 3 or 4 hospitalizations for transfusion, for GI bleeding. The whole thing was pretty miserable. This finally resolved. So this is a picture that Mark Reisman took of a lariat on an excised heart. And what you see on the inside of the heart is this little umbilicus. And if there's a little leak or pouch here, it's easy to imagine that this tissue is inflamed and is a nidus for thrombus. So in our own practice now, we put everybody on something after lariat procedures, ideally aspirin and clopidogrel for at least a month. And I think that after all of these therapies, looking at a TEE somewhere between 1 and 3 months post-procedure is critical to guide decision-making. All of the data we have on Watchman are based on a 6-week TEE, which does guide decision-making, and it really does make a difference if you do or don't see a thrombus, integrating that with the rest of the risk profile of the patient. So I'll conclude by saying that any way we do this, there's going to be a nidus for thrombus, be it incomplete occlusion or complete occlusion with deformation of the tissue, so that I think certainly at this stage, some kind of anticoagulate or antiplatelet therapy should be given for some period of time. And all of that said, if we successfully occlude the appendage and give it some time to heal, but getting people off of everything is highly achievable, and clearly we're already achieving it in the vast majority of these patients. So I'll summarize with this last capsule of the whole concept. Thank you.